Hi, welcome to The Good Fight on Blogging Heads, where we bring people together who disagree and also try to find some common ground. My name is Aryeh Cohen-Wade. I'm the managing editor of Blogging Heads. My guests today are Adrianna McIntyre, who is the managing editor of The Incidental Economist and a master's student at the University of Michigan, and Yevgeniy Feyman, who is a fellow at the Manhattan Institute Center for Medical Progress. And we're going to be talking about the Affordable Care Act, also known as Obamacare today, and the many vexing issues related to it. So my first question for either of you, although I'm responding to a piece that Yevgeniy wrote recently, is Obamacare failing or succeeding or possibly something else?
Um, I think it's obviously hard to judge this early in the game. I think we're seeing that it's certainly not failing. It's not falling into a flaming actuarial death spiral. Um, but there's still a lot of questions that remain unanswered. I think one of the most important is whether and how many uninsured people are signing up for the new plans, what the morbidity status, what the health status of the newly insured population is going to look like. That's something insurers probably aren't going to know until after 2015, until they're pricing their 2016 offerings. So right now, we really have to approach this with a kind of air of agnosticism. We're not sure, but it's certainly not failing in the way that Republicans were hoping that it would.
I would agree, and I would add that I think the media gets it wrong with the focus on young adults because it doesn't necessarily matter how old or young the risk pool skews. It matters that we're enrolling a fair balance of healthy and sick individuals. And it doesn't matter that we meet the White House's goals. It matters that the enrollment actually reflects what the insurers were anticipating. And that's something that we don't really know. So the media has been relying on White House projections and CBO projections, but that's not actually a very helpful metric to rely on.
Yeah, I think Adriana is definitely on point that the CBO metric isn't necessarily some kind of success or failure goalpost. But I think as we're going through this, kind of what we should be paying attention to is how well the CBO is able to make these predictions with how much accuracy. I think we've learned that their ability to forecast healthcare spending, enrollment in healthcare programs is not as great as we might hope. There are a lot of interesting things going on at the same time. We do know that some insurers have been saying that enrollment isn't quite what they were hoping. They obviously can't ask for health status, so they're proxying it using age as best they can. But it's still a long way forward. We have a lot to keep an eye out for.
It's probably going to be months, if not a year or two, before we have a really solid idea of how this first year went.
Absolutely.
So
Uh, what should we make of all the administration's various delays that they've introduced over the past few months? Um, how will this affect the law going forward, and what does it say about how the law was constructed originally?
So I think that the employer mandate delay, which I think was the first major delay, is a really interesting one, in part because a lot of economists weren't fans of the employer mandate to begin with. So it's a political success for Republicans in the sense that it was a delay, and delays are bad for optics. There's no two ways about that fact. Like, delays just don't look good. But also, Republicans and economists don't really care for the employer mandate as it is, and a number of individuals on both sides of the aisle would actually like to see that particular provision of the Affordable Care Act go away. It's really kind of an accounting gimmick to keep the Affordable Care Act deficit neutral because it ensures that a certain number of people achieve coverage through their employers, not through the exchanges, which means that the government doesn't have to pay as much in subsidies. That said, that doesn't necessarily make it good policy. We can go ahead, Yevgeny.
Sorry. I completely agree. I think this is a point that was a little bit underappreciated really early on, that the employer mandate is not good policy. No one thinks it's good policy. We know that the employer-sponsored health insurance market, the fact that we've tied health insurance to employers is an abomination. It's resulted in job loss, lower cash wages, all sorts of terrible things. But I also think that part of it was important to the rhetoric that the president needed when selling the law. It would be very difficult to go to people and tell them you have to buy health insurance, we're forcing you to, but we're not going to force your employers to provide you coverage. That would have made it a much harder bill to sell. And you've seen some Republicans even making a similar argument, saying, well, the president's delayed the employer mandate, so he should try to delay the individual mandate as well. I think those arguments are a little bit baseless, but it's certainly there. The politics of the delay. First, the politics of the delay are very clear, but the politics of having it in the law are also very important.
Right, and I think that another thing that's underappreciated in the politics is that the employer mandate isn't a new idea. It's one of the reasons that Clinton Care sank. There was supposed to be a strong employer mandate, and nobody really wanted that to go forward. And so it was much weaker when they incorporated it into the ACA, but that didn't make it a popular provision. So that's one delay that it doesn't bother me a whole lot. Like I said, the optics are bad. It was kind of the first blow to the first real big blow to the implementation. And it kind of set the stage for the future delays in a way that wasn't exactly great for the administration.
Yeah, absolutely. And I'm honestly hopeful that these delays do weaken the employer mandate enough, at least in the public view, politically, to eventually make it politically feasible to get rid of it altogether.
Well, that leads to another question I'd like you both to weigh in on. I think a lot of these delays are a function of the fact that the law is locked in because Republicans want to repeal it, and if there's some changes that need to be made, they could possibly be made legislatively, and that hasn't happened. I mean, what improvements would you both like to see in the law, and are they feasible under the current political system?
Adrianna, you want to
take this first? The political feasibility is a tricky one. So there's something called the family glitch in the law, and that's, I think, what is most concerning. And it gets really deep into the weeds of the Affordable Care Act. But basically, the way it's determined whether a person has access to affordable insurance is based on the cost of the individual insurance available to them. So if that person has a family, they might not have affordable access to family insurance, but because they have affordable access to insurance for themselves, they don't qualify for a subsidy on the exchange. And that's going to be a really big problem for working class families. And it's something that I think was an honest oversight in the law. It had to do with how the law was passed and the fact that it never got reconciled in conference. And I think that that's something that really needs to be fixed, but I don't know that we'll be able to build the support politically within Congress to do it. And although the administration has managed to tweak a lot of things unilaterally, I don't think that this is one of the things that they could do that with.
Right. So tweaking out that family glitch really messes with the black letter of the law, with the statutory language. So it's much more legally dubious to try to fix that part of the law. When it comes to legislative action, I guess you get rid of the individual mandate, you change some of the qualifications to receive subsidies on the exchanges. So you basically give people a choice between employer coverage and subsidized coverage. I think you can start to address that family glitch, but it's certainly a problem. I completely agree with Adrianna. But part of it, I'll admit, has to do with a privacy issue. Should your employer know how much your entire family is making? And a lot of people are uncomfortable with giving that information to their employer.
And I would say another issue that is actually being resolved in the courts right now, so it might not actually come to requiring legislative repair, is the language around whether we can use, or whether states can have subsidies if they didn't set up their own exchange. And this is an argument that was popularized by Michael Cannon of the Cato Institute and Jonathan Adler, who is a law professor at Case Western. And they have basically put forward this argument that states that defaulted to federal exchanges based on the black letter of the law don't have access to subsidies. I know several law professors who are fairly skeptical that this will go anywhere, and there are at least 2 fairly high-profile cases currently working their way up the court system. But that is something that I definitely have my eye on, because if the courts decide that this is a real problem, it would throw a giant wrench into implementation.
Yeah, 100%. I think Nicholas Bagley on the Incidental Economist has written on this a little bit. I think it's certainly a noble attempt to try to dismantle the law. I think it's pretty much going to be.
I don't know if I would use the word noble. Ignoble, maybe.
Well, I might be overselling it a little bit, but noble given the particular goals of the proponents of this case. I think it's largely fruitless. I think when it comes to the Supreme Court, they'll certainly look at legislative intent, and an honest, rational look at what legislators intended with a law will tell you that they certainly didn't intend for subsidies to only flow through one type of exchange and not the other. It's, in my mind, it seems like it's pretty clear cut. It's certainly might be a close call, but I hope the law is safe from those kind of challenges, because it's not the right kind of challenge, I think.
And one of the biggest problems, sorry,
no, you go ahead.
One of the biggest problems that the law has right now, and it gets attention, but I think people forget that the law wasn't supposed to work this way, is the 20-some states that still haven't decided to expand Medicaid. Everybody below the poverty line in those states that are currently uninsured don't have access to any kind of affordable coverage. And that's a huge problem. And there's no fix within the law, because according to the law, every state was supposed to expand Medicaid. So we're working within this new reality kind of dictated by the Supreme Court after their decision that Medicaid had to be optional. And that would require some serious legislative work, but given the fact that the intransigence on Medicaid is coming from Republicans, I don't see a fix anywhere in the future anytime soon.
Right. So, when it comes to this coverage gap, as a lot of people have coined it, I think the fix, if you can get Republicans to agree on it, is pretty simple. You pull down subsidies to start at 0% of the federal poverty line, so it goes to anyone below 400%. You can pull down the ceiling a little bit. The question is how do you get Republicans to the bargaining table,
to spend
and
the
that's
money.
That's much more difficult.
The problem is how do you get them to spend the money too, because that's going to be more expensive than expanding Medicaid.
Right. So for governors, obviously they'd love this, because they don't need to expand Medicaid. You've got the obvious alternatives. We've got the Arkansas private Medicaid expansion. We've got a private Medicaid expansion as a possibility in Pennsylvania. Republican governors might find that as a good middle ground. It's a tough issue. I'm glad to see that Republicans are finally coming around and willing to at least start offering reform ideas that are beyond repeal. I'm hoping they move past repeal, replace to just real fixes, and there could be substantial fixes, but they've got to cross that threshold.
And I definitely support so what Arkansas is doing, in case viewers aren't aware, is taking their Medicaid expansion population and basically dropping them into the state exchange. And the federal government will be paying for those premiums and for a lot of the cost sharing as well for the new enrollees. And they'll get silver plans. And this was a compromise between a Democratic governor and a Republican legislature. And it was really, really novel and controversial when it was kind of born around this time last year. And something that I think is really interesting. I mean, I obviously think that this is superior to leaving those individuals uninsured, but it's interesting to me that Republican legislators are getting behind that, even though it's going to cost substantially more. It's going to cost both the federal government more, and it's going to cost the state more, because they're still on the hook for 10% there. So I'm curious to see if we have other deeper red states get on board with this.
Yeah, so the fiscal standpoint of the private expansion is a little bit problematic, I think, especially when it comes to Republican goals of fiscal responsibility. The argument, I think, in favor of the private expansion, and some more moderate Republicans can certainly take up this mantle and try to convince the more right-wing Republicans, is just the the care you get under private insurance is going to be better than the care they get under Medicaid. Possibly better outcomes. That's not guaranteed, obviously, but in the long run, it should slow down healthcare spending, if nothing else, simply because of the cost sharing mechanisms included in the expansions. Now, in Arkansas, as I understand it, the under 100% population doesn't have any cost sharing. But if we were to tweak that a little bit, make it similar to the Healthy Indiana program, you could have some cost sharing that I think long term could start bending that cost curve. I think that's how you package and sell it to the really right wing governors, really right wing legislators.
The problem I would
and sorry, just to clarify for our viewers, can you explain what cost sharing means?
Sure. So it basically encompasses everything from copays to coinsurance. When you go to the doctor, if you have a normal employer-sponsored plan, you might have to pay something like a $25 or $50 copay for a standard office visit. That's not a physical, and it's basically to give you some skin in the game beyond the premiums that you're paying, so that when you use healthcare resources, you're not indifferent to going to just going to the doctor every week. Because if you do, you'd have to pay that copay every single time you go.
And I would push back on some of Yevgeniy's earlier points about better private insurance might offer slightly better access than Medicaid. Medicaid reimburses at a lower rate than private insurance reimburses at a lower rate than Medicare. But a recent GAO report found that about 3% of about 3% of privately insured patients had trouble accessing care in the last year, compared to 4% of Medicaid patients. And I think that it gets a little bit blown out of proportion, this question of access, because the way that studies are conducted to determine how many physicians are accepting Medicaid don't tell the whole story. Before 2014, Medicaid didn't cover a diverse population of individuals. It covered predominantly children, infants, pregnant women, and the elderly and disabled, very few working age adults. So you weren't going to see a lot of, gastroenterologists taking a ton of Medicaid patients. And that's going to change, and we're going to have to grapple with more insured individuals with the same number of providers, and that's a topic we can get into. But I think that the access story is more complicated than people on either side of the aisle would really like to accept.
So I actually agree. When it comes to access, if you just look at the national numbers, there's not a huge amount of difference. The National Health Interview Survey has kind of confirmed this a few times already. But I guess what I'm more focused on is what the actual outcomes are. And here's where it gets very difficult to figure out what's driving the outcomes. So if there are some kind of unobserved differences between the Medicaid population and the privately insured population that don't get captured in demographics, you're not going to be able to fully figure out whether private health insurance, by being private health insurance and having cost sharing, etc., has better outcomes than Medicaid, or if it's something inherent in the Medicaid population, maybe just worse health status to begin with, that makes them have worse outcomes. But I think when it comes to outcomes, the Oregon health insurance experiment, where we can get into this a little bit more, which was the gold standard, the randomized controlled trial, makes it a little bit problematic to argue in favor of Medicaid's outcomes. There were certainly problems with the study; it was underpowered, but it's not as simple as saying we'll give you 100% actuarial value insurance, and your blood pressure is going to drop, your mortality risk is going to fall, and you're going to be just a million times better off.
Right. And I mean, I would go immediately to the power issues. You can't use the Oregon Medicaid study to really tell you anything about physical health outcomes, because it wasn't powered to tell us anything. The Oregon Medicaid study, in Oregon, they had...
Yeah, please give a little background on this.
So in Oregon, they wanted to expand Medicaid to include more working age adults, and they had funds to do a partial expansion, but not to cover everybody that they would have liked to cover. And so they held a lottery, which for researchers was very exciting because it functioned as a randomized controlled trial. In theory, there was nothing about there were no serious differences between the people who won the lottery and received Medicaid coverage through Oregon's Medicaid program and the people who had applied for the lottery but didn't receive coverage. So the researchers tried to compare these two populations along different metrics and determine whether it improved physical health, mental health, financial stability. And they found statistically significant improvements in depression, in self-reported health, and in financial security related to health expenses. What they didn't find was statistically significant results related to, for example, blood pressure. But one really big problem with that is that they compared the uninsured and the new Medicaid population without kind of pulling out the people who had high blood pressure. So you're comparing this big group of people with all sorts of different levels of blood pressure, high, low, normal, in the two groups. So you're diluting any effect that's happening there. And if you had wanted to look at just the people with high blood pressure, you wouldn't have had a large enough sample size to detect clinically significant changes. And so that's a really big problem. You can't necessarily say, well, the Oregon Medicaid study proved that Medicaid doesn't improve blood pressure. It didn't prove anything about blood pressure.
Yeah, I completely agree. It's a problematic study in terms of policy. I think when you pair it with previous studies that we know about free health insurance, so the classic is the RAND health insurance experiment, which was also a randomized trial, and here it was comparing two different types of insurance. It was comparing an insurance with a high deductible versus free insurance, basically with no cost sharing. So somewhat similar to Medicaid, and there they found that the only two real improvements to those who had the free care came with better vision and slightly lower blood pressure. But along, I think it was 4 or 5 other metrics, they found no statistically significant difference.
Correct me if I'm wrong.
Sure, go ahead.
RAND didn't have an uninsured population.
Right. It did not. And here you get into the question of whether the uninsured population is healthier or sicker than the currently insured population. This one of the problems with CBO modeling is, as I mentioned before, CBO assumes that the uninsured are actually healthier, whereas a lot of actuaries like Oliver Wyman and Milliman tend to assume that the uninsured has a higher morbidity, that they're sicker than those who are currently insured. So your priors matter a lot here. In the end, we're all Bayesians. We all have to compare it against prior distributions. And with Medicaid, it's difficult to do on a national level, in my mind, because each state varies so much. The Medicaid program in each state is a very unique program. That's a problem I have with looking at the Oregon results and trying to extrapolate them nationally, but the few takeaways from that mesh with prior studies seem to be relevant.
So is it a point of disagreement that Medicaid expansion is the way to go? I mean, Yevgeniy, do you think that a private model along what Arkansas is doing would be better for the health of people who would otherwise be getting Medicaid expansion if the Supreme Court hadn't ruled that it was no longer required?
So I do think giving people private insurance is better than giving them Medicaid, contingent on having some kind of cost sharing in that private insurance. When you don't have that cost sharing, I think you take away an important element of private insurance. I don't think having broad physician networks is key to any health outcomes. I think having narrow networks can still work for a lot of people. For the sickest populations, managed care can work really well. So I think private expansion with some level of cost sharing, you can make it waivable below the 100% of the poverty line. But I think that cost sharing plays an important role in influencing certain health improving behaviors.
And I'm skeptical that you're going to see much of a difference between if you enroll these people in public Medicaid versus a private plan on the exchange. Something that's really interesting, I'm from Michigan, so I pay more attention to stuff that's happening in Michigan than other people might. There was a survey done in the last year or two that found that Medicaid recipients in Michigan are actually happier with their coverage than people in Michigan's individual market. And so I don't know if that reflects better networks or if it reflects better benefits. But one thing Michigan is doing, Michigan recently signed on to the Medicaid expansion, that I think Yevgeniy and I might agree on, is they're trying to incorporate value-based insurance principles into their new Medicaid program. So that means that they will pay the entire cost for treatments that they consider high value, like good bang for your buck. You're doing something that will be improving to the patient's health. And they're imposing cost sharing where they're allowed to for services that might be less valuable. And I think that that's something that could be a point of agreement for people on both sides of the aisle, although Medicaid as a program faces a lot of stigma on the right, I sense. And so even trying to reform it incrementally might be difficult.
Well, I'll start with the first point you made. You know, people are more satisfied with Medicaid than the individual market coverage. I would be too if you give me insurance that's going to pay for everything and I don't have to put any money out. I'd love it. So that doesn't really surprise me. I think value-based purchasing programs can work. I'm a little bit skeptical just because I haven't seen them work very well in fee-for-service Medicare. I'm also skeptical of whether government bureaucracy can really ascertain what are high-value treatments or not. It depends who's testing them. It depends what the standards you're holding these treatments up to are. Are you using regular frequentist trials? Are you running more adaptive trials? What do you consider to be valuable? Does it just have to cross a certain threshold, or does it really have to be statistically significant? There are a lot of questions here, but in principle, sure, I'm all for adding more value-based purchasing into Medicaid, even reference-based pricing. If that's politically feasible.
The thing about cost sharing is when we're talking about the Medicaid eligible population, we're talking about individuals making about $15,000 a year or less, and we're talking about families of 3 making less than $27,000 a year. So cost sharing isn't just something that is incidental to these families' budgets. It's something that's going to be very, very problematic for them. And so that's something that I think I value the protections that Medicaid has for the low-income individuals who benefit from it.
Yeah, I agree. So for someone making $15,000, even a $50 copay to go to the doctor, that can be a pretty big burden. It can mean the difference between buying food for the next week. So I completely agree. If you're going to use cost sharing, you have to do so wisely. So I looked at a Healthy Indiana program, and what they did was pair a health savings account, an HSA, with a reform to their Medicaid program, and there was pretty huge uptake. If I remember correctly, they required some percentage of income to be contributed to the HSA for certain slightly higher income Medicaid beneficiaries, but for lower income, the state funded it completely. There was high uptake in the program. I haven't seen any outcome data yet. I think they haven't gathered that yet. But unfortunately, the program is going to be shut down because the federal government refused to grant them a waiver. That's unfortunate. I think experimenting with those kind of those forms of cost sharing, where you have some kind of government funded HSA, or if you have cost sharing that's waivable. I think Iowa is trying something like that. Kentucky, I believe, they're going to make some levels of cost sharing or premiums waivable if you do a health screening, or if you enroll in a smoking cessation program if you're a smoker. So again, it comes down to what can you do to encourage health positive, so to speak, behaviors, and I think that's crucial. A lot of health outcomes are related to behavior, much more than just having health insurance.
Healthy Indiana was a really popular program in the state and with its beneficiaries, and Milliman has a fantastic paper on it. One thing I seem to recall from that paper is that once beneficiaries became kind of high-cost beneficiaries, for example, if a woman enrolled in Healthy Indiana got pregnant, she was moved into the traditional program. So this is a kind of structure that works great for the healthy, but it's not necessarily the kind of insurance that people who have pre-existing conditions would benefit so much from.
So, you might be right. It might be that the ideal Medicaid program is actually a program where the really, really sick don't have any cost sharing. If you have cancer, God forbid, your cost sharing is completely covered. You don't need to put any skin in the game. But then for those who don't have a pre-existing condition, who might be in the standard Medicaid program, you don't want to be encouraging them to go to the ER, for instance, for basic checkups. As we saw from more results from Oregon, because there's no cost sharing, because there's no incentive to go and seek out a freestanding clinic or a freestanding physician's office for ordinary care, people went to the ER disproportionately. You can discourage those kind of behaviors. I mean, every time you set foot in a hospital, your risk of getting an infection skyrockets. You really want to target it to the people who can help. I don't think cancer patients who are making $15,000 a year should be shelling out, 15% coinsurance for their $100,000 cancer treatment. But I do think someone without any pre-existing condition who, might be smoking, just might be a riskier person, should definitely have some kind of cost sharing to encourage healthier behaviors.
I would actually be on board with imposing copays on visiting the emergency room for non-emergent conditions. And I think that that's something that, you wouldn't face a whole lot of disagreement from economists. There are a lot of problems with people seeking care in the emergency room. It's not just a matter of convenience. There are some qualitative studies that show low-income individuals actually have a degree of trust in the emergency room that they don't have for primary care, in a way that isn't necessarily common sense, but it's something that comes through in interviews with patients. That said, another thing I seem to recall from the Healthy Indiana plan is that it didn't necessarily save a lot of money. It might have cost marginally less than traditional Medicaid in the state, but for the most part, it was a different way of delivering care, and it was a different way of financing care. But it didn't do a whole lot to actually bend the curve or change the amount we're spending on care. And if that's what we want to do, we need to do more than just say, here's a health savings account, put some money into it. That might help a little bit, and I feel like it requires an outside party. So with Healthy Indiana, the government put some money into the HSA because the individual might not be wealthy enough to do that themselves. They were qualified for Medicaid, so they were very low income. With employers, I think that HSAs hold some promise too, because the employers can contribute some of the employees' wages. When you're telling people, here's an HSA, put some money into it in the individual market, I think you face some problems. I think it's a problem we see with retirement accounts, where people aren't putting money away because they're, discounting rates, right? Economics.
Right.
So I think that there's a blind faith in high deductible plans paired with HSAs for the individual market that Republicans harbor, and I think that could get dangerous if we think that we can rely on them within the individual market.
So, if you take someone who's not poor, middle class, making maybe $55,000 a year, so somewhere around the per capita or median income. If you really give them an incentive to save over time, and I think this is where HSAs tend to shine, that they're portable, first of all, so you can take them from job to job, but they also carry over year to year. You put in $500 a year because it's pre-tax. You can reduce your tax liability. By doing so, you get a lower premium plan, so you can just take the difference of the premiums and put them into an HSA every year. Over time, you build a pretty nice cash reserve. The question is encouraging people to do that, and I acknowledge it's very difficult to encourage people to save. I think there's some really, really interesting stuff going on in the employer market. Unfortunately, we're not seeing it in the individual market yet, but companies like Castlight, they're offering these really nifty services that employers can pair with high deductible plans, where they really show you the price that you're paying for care. They make it very clear how much you're saving in total costs on average by moving to a high deductible plan with an HSA versus a typical PPO that doesn't really have a deductible or has a fairly low deductible. And when it comes to retirement accounts, I think I don't want to say that there's a consensus, but part of that certainly has to do with with the payroll tax. There's a pretty big discouragement to saving in this country, and our savings rate is quite a bit lower than where it should be. It's lower than the OECD average. That's a different discussion, I think, but it's certainly problematic.
Yevgeny, so do you see HSAs as a way to bend the cost curve overall? I actually have a personal anecdote. I actually do have a high deductible health plan, and my doctor recently said I should have a procedure. I asked him how much it costs, and he said he didn't know. And it seems like, pricing is very opaque in the health realm.
Right.
And, the average consumer is not necessarily well informed enough to make kind of these cost-benefit decisions. So it seems like this is, not ultimately a way to get to control costs. And I'm wondering whether you think, we're eventually going to reach a place where, the government is just setting the rates as it does with Medicare.
Right. So Uwe Reinhardt has made this point before that the idea of high deductible health plans is very problematic without transparency in the market. In healthcare, you don't have prices. The prices you do see are not real prices. They're not indicative of quality. They vary randomly. In some cases, we see patterns of healthcare usage in counties across different states that vary for no good reason, that have no association with the health status of that population. So I think if we enact more transparency reform, I just want to caveat that by saying doing so by fiat is very difficult. But with more transparency in healthcare prices, that's how HSAs would work. Without people actually knowing what the price is, without a person knowing, this procedure costs $500 if I do it here, but it'll cost $200 at this clinic. Without that kind of transparency, there's absolutely no way for HSAs to work. And on top of that, you need good quality information, which we certainly don't have. I'll be the first to admit that. I'm optimistic that we can get there if we start getting more people into high deductible plans. There's going to be more demand for these middlemen like Castlight and other services that provide the transparency and quality metrics that you need.
Yeah, I mean, I think we're kind of at a turning point with transparency in a very good way. I think that Steve Brill's article, Bitter Pill, kind of brought this to, the public consciousness in a way that nothing else really has. Economists have known for ages that health markets don't work like regular markets, and lack of price transparency is one of the reasons. I mean, there's a reason that we have health economists and we don't just call them economists. It's a different kind of economics because the market doesn't function like a normal market. And so price transparency, I think, is a necessary but not a sufficient condition for starting to get our health spending under control. I definitely see that as a problem with high deductible plans in the way that you described, Aryeh. And it's kind of like a chicken and egg problem, right? So what comes first, the price transparency or the plans that induce price transparency or demand price transparency? And I'm not sure I have an answer to that question.
So, that's a good point. It's hard to say which necessarily comes first. So what we're seeing in the employer market, I think, is pretty encouraging because employers are realizing that the supplier side of healthcare, mostly dominated by hospitals, they're really the big players. The employers are realizing that in order to have some leverage, they need to band together. So you're seeing some associations form, the Northeast Business Group on Health, for one, and what they're trying to do is get their members to really to take a step back and look at their healthcare costs and figure out what they can do to lower them long term, while still being able to offer value to their employees. EBRI, they did a study of this full replacement HSA for a Midwestern employer, I think. So there, it was generally younger workers, certainly a better health status rather than the rest of the country. But the full replacement HSA ended up saving money. I think something like $500 per person in the first year, a little lower after that. But it definitely reduced spending. They didn't track outcomes, so it's very possible that people might have avoided necessary care. But in terms of costs, it made a dent for that particular employer. That being said, again, I don't think that someone with a chronic condition should be having a high deductible health plan. They should probably be in a managed care plan. We've seen those work pretty well in Medicare Advantage. There you get into the question of retention and stickiness. Managed care works if you're in the plan for 5-10 years. If you're just in the plan for a few months, like people have been in Medicaid MCOs and Medicaid managed care organizations, if you're in the plan only for a few months and you leave, that's not going to do much for you.
Yeah, and I mean, Yevgeniy just highlighted one of my big problems with HDH, high deductible plans, which is that they are designed for people who are healthy. They're designed for people who don't have frequent health expenditures. And so you hear people toss around the word death spiral when we talk about the ACA, right? The classic study that the word death spiral kind of comes from is a study on health benefits that were at Harvard. It's a Harvard study based on employer insurance given to Harvard employees. And basically, Harvard introduced a high deductible plan into their health plans available to employees. And suddenly, all of the healthy employees were flocking to this cheaper high deductible plan, leaving the more expensive employees in the more generous plan, which drove up premiums, which drove healthy people out into the high deductible plan in this, spiral sense. And so when you start talking about having high deductible plans for the healthy, what you're really talking about is risk rating, and rating, which is what we're trying to move away from with the Affordable Care Act. There are a lot of people who have value disagreements about whether we should risk rate or whether we should do what's called community rating, where everybody, within a certain age band is charged the same rate regardless of health status. But when you start stratifying plan generosity, you're going to start stratifying on health status, and you're going to have sick people paying more. And I think that that's somewhere where people of different ideologies actually divide, and that's part of why it's so hard to reconcile health policy, because I would prefer not to see us charging sick people more. And I feel like a lot of plans coming out from the right are kind of okay with that. Not necessarily at the extreme, but in a lot of ways, they're okay with saying, okay, we're going to treat the sick people differently. And you can argue about whether that's good or bad.
Right. So,
Yevgeniy, do you think sick people should have to pay more?
I think it's a very complicated question. So if you come at this from a moral perspective, it's a question of, are you sick because of pure bad luck, or are you sick because of things that you didn't do or things you did that either could have prevented or exacerbated the condition that you now have? So, it's very difficult to make those kind of judgments, and you want to avoid telling people that it's your fault that you're sick now. It's your fault that you have lung cancer because you smoked for 40 years straight. That being said, this is something we have to take into consideration from a moral perspective if we're going to judge whether risk rating is a good thing or not. I'm kind of at the point where I've accepted that we're going to have community rating on health status, but I think there are alternatives out there. High risk pools, although before the ACA they were largely failures. Minnesota's high risk pool worked pretty well because it was well funded, and premiums in the high risk pool were capped low enough that there was pretty strong participation. Now, it was funded by surcharge across all insurance plans for every single person they sent to the high risk pool. So you were transferring risk. You were kind of doing so at the back end, though, while at the same time those surcharges were obviously passed off to the healthier people who bought plans in the regular individual market. So you were essentially transferring based on health status, but in a more transparent way, I think.
I would maybe argue about the transparency of it. So high-risk pools is basically, these are health plans for people who have pre-existing conditions or really bad chronic conditions and have really high expenditures. And in the past, people in high-risk pools have found the premiums to be unaffordable, which makes them really ineffective at actually providing coverage. If people can't afford the coverage, then they're not going to have it, and then they're going to be going uninsured when they can't afford to be uninsured either. And the way I see it, if you have a high-risk pool and it's subsidized, it's going to be subsidized through taxpayer dollars in some way or another. And so you're just finding a different way to finance this. At least with community rating, when you're putting everybody into the same pool, everybody's also getting the same benefits. Whereas with, people who are healthy having slightly stripped down plans, but also paying taxes to fund these high-risk pools, they're helping to subsidize the sick. And at the same time, they have more limited benefits in their own plan. And they may not need those richer benefits, but something might happen where they do need those benefits in the future. And they would then have to go into the high-risk pool, and those often have waiting periods, and it would just be kind of a headache administratively. And I personally think that community rating is the more transparent, more straightforward way of approaching health insurance.
Right. So my big problem with community rating is, it does create this disincentive for healthier people to enroll, because it seems to increase premiums for those people more so than having some kind of surcharge or a fee for insurers. That being said, I don't know of any studies that have actually compared, that have tried to model a high risk pool versus community rating, which is more, which one is more transparent, which one ends up with a more equitable distribution. So I really have to hedge my support for high risk pools, given that uncertainty. But it's certainly another option, I think, on the table, as opposed to community rating. That being said, I don't think it's politically realistic at this point.
The thing that drives me really... Can I go ahead?
Sorry, Adriana, go ahead. No, you go ahead.
The thing that drives me really, really nuts about this ideological debate about community rating in the Affordable Care Act under the ACA is that we've had community rating in the employer-sponsored market for decades. And I know that Yevgeniy isn't a fan of our employer-sponsored market, so I'm not putting this on him. But we have had, I worked at the same hospital that my mother worked at for a year. And I came in as a 22-year-old, and I was paying the same premium that she would have paid as an individual, even though she's, 30 years older than me. And that was being taken out of my wages. Economists know that even though employers subsidize a lot of the insurance premium, that's basically foregone wages in economic terms. And nobody's really been outraged about this since this has been the practice. I can't even think of a date to pin this to, the 1930s maybe, that we've been doing this. And suddenly the Affordable Care Act says, okay, let's do that, but let's not be so extreme. Let's introduce age bands so the young aren't totally subsidizing the old. But it's still this huge, huge controversy that suddenly the healthier are subsidizing the sick, when that's been the practice in the employer market, which is the predominant market of health insurance in the United States, and in pretty much every other developed nation's health insurance system since health insurance became a phenomenon, more or less.
So here, my issue with a comparison, I guess, to the employer market is, we know that it's very inefficient. The employers tend to pick up a really, really big chunk of the premiums. I don't know off the top of my head what the latest numbers from
it's probably
Kaiser's
close to
survey of this.
3/4.
Yeah, I think it's 3/4 for families. It might be a little higher for individuals. So the employees are already just getting subsidized much more than they'd be subsidized on the exchange. And this ends up being very expensive. It's about $250 to $300 billion in foregone tax revenue every single year. So it isn't cheap. We do so in the employer market. Employees like it because they get very cheap insurance that's very, very comprehensive.
They think it's cheap because they don't know that they're foregoing wages in a sense.
Exactly. They're not price sensitive at all in the market, because they manage to have comprehensive insurance that's 85% actuarial value, I think, by one of the last estimates. So it certainly makes sense that employees loved this arrangement. Now, when they really have to subsidize more out of their pocket, when they're subsidizing the sick and they're really feeling it, it's understandable that it becomes a bigger issue for them.
I understand, like, I get that it's more salient when you actually have to pay out of pocket and it's not your employer. Like, that makes sense to me. I just don't understand how this hasn't, at some point in the last 4 years, translated into Republicans saying, well, maybe we should change this in the employer market too. There is some latitude to impose age rating. It's the law is like really, really complicated, obviously. But nobody has said, well, maybe we should tinker with the employer market to reflect the values that we're promoting under the Affordable Care Act, or the values that we would like to promote, but the Affordable Care Act is preventing us from promoting. So it's just kind of an intellectual inconsistency that bugs me.
Sure, I understand where you're coming from. I think when it comes down to it, employers probably wouldn't want to do that to begin with, because for them it's an important value proposition to their workers. It's a very inefficient value proposition from a tax perspective, from an economics perspective. But I think employers are happy keeping it as is, because it helps keep the best and brightest working for them, right? It's part of the efficiency wage theory. Kind of.
I have a question that's maybe more general and philosophical. How should we think about health insurance? Is it a privilege? Is it a right? Is it a responsibility? Is it something else?
So I'm not somebody who goes around saying that health insurance is a right, because I don't think that that's the appropriate rhetoric to couch this in. The way I see it is that we are the wealthiest nation in the world, and we have a moral imperative to provide certain basic needs, or basic privilege still isn't the word I would use, but certain services to our citizens. And I would say that health insurance is one of those. And the fact that we can't manage that, even though pretty much every other developed nation and some less developed nations can, is an abomination to me.
I agree that universal coverage is a noble goal. I think for liberals, it's very clear why it's a noble goal. I think it's been harder for conservatives to take up that mantle, but it generally meshes pretty well with conservative values. I think when it comes down to taking care of the indigent, those who are unable to take care of themselves, conservatives were able to muster the support when it came to passing Medicare and Medicaid in '65. It was passed to a large extent with the support of Republicans and conservatives in Congress. For some reason, some conservatives have trouble taking on universal coverage as a noble goal right now. I think that's a big problem. Now, that being said, I don't think we should confound health insurance with health care. It's important that if you're giving someone health insurance, that it does give them the opportunity to actually get health care. We've talked about this a little bit when it came to Medicaid, but health insurance, I think, should be focused on catastrophic expenses. There are a lot of ways to think about what the optimal kind of health insurance would be. In my mind, it would be deductibles or copays tied to your income. But I think broadly, yes, universal health insurance is a good thing, unabashedly.
I still have a hard time. So conservatives default to this concept of catastrophic insurance a lot. And I think that you have the best intentions when you do that. But you don't tend to define what you mean by catastrophic. Is that a set of benefits, or is that a dollar amount as a percent of income? Or how do you personally understand catastrophic coverage?
So when I think of catastrophic coverage, I do think of it as a percentage of income. Administratively, this is very difficult to do, and I'm not an actuary. I can't tell you how to properly build these plans. But I think you have a system of progressive deductibles tied to income. So for the really poor, it might be 1 or 2% of their income. For the really wealthy, those making $2, $3, $4 million, it could be 40-50% of their income. That's what I think is really catastrophic coverage. When it's relative to what you're making every year and not just a fixed dollar amount.
Fair enough.
Okay, so you guys have been entirely too reasonable in this conversation.
We've
had a lot of agreement. We've had a lot of agreement.
After you emailed us, I actually sent Yevgeniy an email saying, "Where do we disagree?"
Yes. It took a little while to find some good topics where we could reasonably disagree a little bit.
Yeah. So, I mean, is there anything else that you think is a disagreement between you two that we should discuss briefly at the end here?
Adrianna, what do you think about Medicare Advantage?
I mean, there's nothing about Medicare Advantage that bugs me. I don't think that Medicare Advantage is subpar because I would never say Medicare Advantage is private and therefore there is some problem with it. The problem I have with managed care generally is that it encourages a gaming of the system, right? So even when you put in all of these different mechanisms, these administrative mechanisms to shift risk around and to make sure that insurers are reimbursed for taking on sick enrollees, it's just creating new rules for a game. And insurers know that, and so they try to find the beneficiaries that are most suitable for that. And you see it in Medicaid managed care as well. There is a study I read a while ago that found that Medicaid managed care organizations try to shift the sick beneficiaries onto their competing managed care insurers. And so that's kind of my problem, is it creates a really complex layer of administration. And I don't know that we see a ton of added benefit for all of that complexity.
Right. So I agree. And
we're really bad at disagreeing.
I'll disagree with one part of what you said though. So in general, any time you have a government insurance program, there's some kind of incentive to try to game the system. So even under the ACA, when insurers started offering plans, to some degree, the plans were underpriced because you have these federal backstops, the 3 R's, risk corridors, risk adjustment, and transitional reinsurance, that make it profitable, at least for the first 3 years, to enroll relatively unhealthy people. Right. But they also underpriced to try to capture market share. So you're gaming the system by underpricing your products relative to your competitors, where the price is actually below the equilibrium price. That's as much a gaming of the system as trying to favorably select the healthier population. When it comes to Medicare Advantage, my biggest optimism comes from the outcomes for the sickest beneficiaries. Boston Consulting Group did a study of one MA insurer, I think over 2 or 3 million patient records, and what they found was, for those people with the most comorbidities, the most chronic conditions in one person, you had the biggest improvement relative to fee for service. And the nice thing, they use really a really clever method. They use sample matching to try to kind of simulate a randomized trial. It's imperfect, but it's about as good as you can get in this case. And it's just phenomenal. Mortality both for first year and second year just fell drastically for the MA population. And I'm not completely opposed to the changes that the ACA makes to MA to reduce some of the perceived overpayments. I would have just done it a little differently. I would have switched to a premium support model and just let Medicare Advantage insurers fight it out between FFS, fee for service. If they can't make it in that market, then they shouldn't be in the market, period.
And what I think is really interesting about that is it kind of builds an argument for a public option, doesn't it? For the exchanges, if there's a market that if it's great for private insurers to be competing with Medicare fee-for-service, shouldn't it be great for exchange plans to be fighting with a private or a public option?
So, I've thought about that a little bit. John Goodman made an interesting proposal recently. He proposed to just let people buy into Medicaid. I'm mixed on that because again, when it comes to a public option, if you were to just make it Medicaid, for instance, the way you're generating savings is really just by using monopsonistic buying power to pay providers much less than what private insurers are paying. That being said, I think in areas where you have highly concentrated hospitals, this is more of a problem in rural areas than it is in urban areas, but where you have one or two hospital systems dominating the market, a monopsonistic buyer may not be the worst thing in the world. I don't think I'd want to just have the Medicaid program as it is on the exchange, but so something that resembles a narrow network PPO option. I'd be happy to give that a chance.
Okay, I think that we've gone about an hour. I think that's probably a good place to stop. Thank you so much, Adrianna and Yevgeniy, for coming on today, and
Sure.
thanks to
us.
our viewers.